Yeah, thank you. So now we have one of the very prolific young dynamic surgeon, Dr. Supriya, who will be presenting on their experience with geometry. All to you, Supriya.
Thank you so much, sir, for the kind introduction. It's a pleasure to be here. Today I'll be bringing us back to the trifocal lenses.
Can we have the slides?
I think it's a different slide.
There's something else.
It's connected to the laptop here.
This one way of telling us our time is over.
Indirectly. So I think for the next session, we'll just take quickly 6 minutes. Sorry for that, running out of time. Okay.
I'll be quick. So I'm just bringing us back. I think everyone's hungry, ready for lunch, so I'll keep it short. Bringing us back to the trifocal lenses and our experience with the combination of geometric in one eye and geometric plus in the other eye. So as we know, the expectations are high these days with trifocal lenses. The other day I was counseling a patient, and like Dr. Anaga initially said, that the first question we generally ask them is, do you do a lot of night driving, a lot of activities at night? And the patient said, no, absolutely no night driving. I've stopped doing the night driving right now. It's done. I only drive during the day. And then I said, okay, if the night driving is, not a major activity in your life, then you can consider trifocals, but you also have these other two options, which are also there. And then they said, anyway, since my near work, my reading is not too much. This was an elderly lady. She was a housewife, not too much night driving. She does drive during the day. And she said, okay, I'll go for a plain monofocal lens. Then I said, okay, can I drive during the day with a plain monofocal lens? I said, yes, absolutely. Your distance vision, quality of vision, clarity, contrast, everything will be really great. For distance vision, you can drive with a monofocal. Then she says, while driving, I can see everything clearly on the road, but I can see my dashboard also very clearly, right, with the monofocal. Then I say, yes. I mean, the intermediate vision would be probably better with an EDOF lens. So you can consider an EDOF lens. And then she says, when I stop in the middle at the signal, sometimes I check my phone and I read my messages. I'll be able to do that, right? And then these are all the activities that I do during driving. I drive during the day, so I'll have all of these activities intact. I don't want to use spectacles in between every time I stop at a signal. So then, these are the expectations of patients from these lenses to correct all of their distance, intermediate, and near vision. So then I counseled her for this lens and said that trifocals are better for her since she doesn't have, night driving or activities at night, and she does actually want a good near vision. So expectations from patients are very high. They want to enjoy life in all dimensions and have an active lifestyle without being troubled by glasses. Now, the trifocal lenses that we use in our practice are the Hoya Geometric Plus lenses, Panoptic lenses. We use Zeiss trifocal lenses, Technis Synergy, and the Rayner trifocal lenses. And the way we counsel lenses and how we actually choose the lenses, again, depends on the activities of the patients and at what level their intermediate work is. So we check the reading distances and check the distances at which they are doing their near and intermediate work. So trifocals were developed to bridge the gap between monofocals and bifocal IOLs in order to provide a significant advantage in terms of postoperative unaided vision and creating a true intermediate focus. It should be noted that an added intermediate focus also causes 2 permanent defocus images instead of 1. So this is a much greater complexity in the manufacturing process, and both of which could degrade the optical quality of the vision, which is why we have patients coming back to us speaking about glare, halos, dysphotopsias, etc. And let's see how these lenses have minimized those effects. So here talking about the Vivinex Geometric and Geometric Plus lenses. Now, there is always a confusion in these lenses, and everyone asks me, is this a mini mono vision? Do you have to check dominance? Do you have to do the tolerance test? Do you have to check dominance? And the answer to that is no, this is not a mini monovision. Both the eyes have a near add of 3.5 and an intermediate add of 1.75. And the target refraction for distance for both of these lenses remains 0. So you're not targeting one eye to be slightly myopic. Both eyes are targeted for 0. The difference is that the light, 100% of light entering bordering the eye is split into 3 different foci. And the amount of light that is split into these 3 different foci is variable. So this is the first company that has actually done this, where they have played around with the distribution of the light rather than having 2 different near ads or having 2 different target refractions for both the eyes. So you're actually fully correcting the vision. There's no refractive error for all distances. You're correcting the distance, intermediate and near refractive error as such. But you're just playing around with the light distribution in both the eyes. So the geometric lens provides excellent distance vision, good intermediate and near vision, while the geometric plus lens provides excellent near vision and good intermediate and distance vision. And toric versions are available from T2 to T6, and it has this preloaded multi-cert injector, which is one of the smoothest injectors that we've ever used. You can use it either as a screw type or a push type injector, and you can actually adjust the nozzle as such, depending on whether you want to do a wound-assisted implantation or inject the nozzle fully into the wound. Now, these are just some of the other details of the lens. It corrects the powers between 10 to 30 diopters, and the recommended incision size, the wound goes, the preloaded injector goes easily in a 2.2 mm incision. So this is the light distribution, like Dr. Anaga has previously attributed to the light distribution in the geometric lens. It splits the light mainly for distance. So 50.8% of the light is distributed for distance, 17.3% for intermediate, and 21.8% for near. Now this is very similar to the other trifocal lenses, where the light distribution for near is somewhere around 20 to 25%. But in the geometric plus, we can note that the light distribution for near is around 32.8%. So much larger light distribution for near, which helps in greater contrast, color vision, and quality of near vision. Okay. So the same add powers are there in both geometric plus is what we've spoken about. But here you can look at the percentage of light loss. So any trifocal lens, yes, there is some amount of light loss. Most trifocal lens, the light losses are around 12 to 14%. But in these particular lenses, it's between 10 to 11% light loss. So light loss is also minimal, but light loss is there since they are diffractive lenses. In our experience, we did a study, 52 eyes of 26 patients with cataract from grade 1 to 4 nuclear sclerosis, and patient had the second eye surgery within 1 week. All patients underwent femtosecond laser-assisted cataract surgery by one single experienced surgeons, and 2-week follow-up were available for all these patients. Now here you can see that 98% of eyes were 6/6 or better at post-op 2 weeks, and all eyes were 6/9 or better. The binocular near visual acuity, you can see that 100% of eyes were N6 and 39% of eyes were even N5. And this is the combination of geometric in one eye and geometric plus in the other eye. The postoperative residual refractive error at 2 weeks, you can see that 94.23% of eyes were within plus or minus 0.5. So this is a great refractive result. We did this test, Salzburg reading test. Is basically a tool for symmetrical evaluation of reading acuity and reading speeds under standardized condition. So this is a patient performing the SRD test. So the reading acuity at different distances, so 40 centimeters, 66 centimeters, and 80 centimeters. So here we found that the visual acuity at 66 centimeters, which is generally the reading distance, was the best. And the reading speeds, that is how fast the patient is reading, number of words per minute, this was also the highest at the 66 centimeter mark. Again, this is the defocus curve. This is something that we've already spoken about. Now, defocus curves are something quite fancy terms that are thrown around, but it's a very, very simple test. What it means that we are inducing a defocus or a spherical power as such. So we make the patient read without glasses, and we make them read the chart, and then we add a defocus, either a plus defocus or a minus defocus, and we make them again read the chart and see the visual acuity with the defocus on. So here you see that without any power at 0, the vision, the logmar is 0.058, somewhere around there. So it's excellent vision. With a minus defocus up till around -2, you see that it maintains. So in the defocus chart, something important to note that anything more than 0.2 logmar is considered functional vision. So you see that you are getting an excellent functional vision up till around -2 to -2.5 defocus. Patient is tolerating that very well, and even a slight plus defocus of 0.5 is well tolerated. This is the contrast sensitivity chart, the FACT chart. So here you see that, any trifocal lenses, yes, they have a subnormal contrast sensitivity, but these lenses, the combination of these lenses are coming almost within the normal range, the lower end of the normal range. So the contrast is also quite good as per the FACT chart. We asked the patient and did a scoring questionnaire where none of these patients actually came back to us complaining about dysphotopsias, but that's generally not how we assess it. We need to ask them positive leading questions about dysphotopsias, and that's what this questionnaire does. And on actually asking the patients if they're seeing glare, seeing halos, seeing dysphotopsias, most of them, some of them, about 9.54 out of 10 of them said that they were not uncomfortable with these dysphotopsias or didn't see them. The rest of them, yes, they did say that they did see some disturbing light phenomenon at night, but they were not, it was not affecting their lifestyle as such, and there were no complaints as such. So trifocals provide improved near, intermediate, and distance vision in presbyopic patients. The use of 3 foci provides significant intermediate visual results without sacrificing near or distance vision. Pairing the geometric and geometric plus, we have found, gives one of the best continuous range of high-quality vision for spectacle independence from distance to intermediate to near. And in our practice, we have used the pair of geometric plus most often for our patients, and we see excellent results with the pairing. Thank you very much for your patient listening.
Very nice presentation, Supriya. I think we have a great family of lenses, excellent material, hydrophobic acrylic, absolutely glistening free, posterior surface modification, which are SPCO, square edge, and then you have the roughening of the haptics so that the rotational stability is there. Then, of course, the trifocal and trifocal plus, which has a unique USP of being the only lens where the light distribution is paired between the two lenses. Overall, and then of course the Impress, which gives you a monofocal plus platform where you want to get some amount of intermediate vision, but where dysphotopsia is a concern. So truly a great platform, and nice to have multiple choices available to us, and this Hoya group of lenses is something we are all getting accustomed to. And I think the speakers in this session truly did justice to all the different aspects of this wonderful lens. Thank you so much.